Good evening, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and we are looking forward to tonight's topic, Efficacy and Safety of Taltz in Plaque Psoriasis and Psoriatic Arthritis. As moderator this evening, we have Dr. Firas Hougeir, and he is a Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of Southeast Dermatology Specialists. As speaker this evening, we have Dr. Brad Glick, member of the AAD Board of Directors, Residency Program Director, Larkin Palm Springs Hospital, PI GSI Clinical Research, and ASDS Advocacy Ambassador from Miami, Florida. We'd like to thank our supporter this evening, Lily, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser, and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. And lastly, within 1 to 2 days of the webinar, you will receive your certificate of attendance. It will be emailed to you. Again, if you have any questions for our faculty for the Q&A portion of tonight's webinar, please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I'd like to pass the floor virtually to Dr. Hougeir.
Good evening, everybody. It is my pleasure to moderate today's symposium, today's talk with Dr. Brad Glick. Today's symposium is provided by the International Dermatology Education Foundation, whose president and founder is Dr. Leon Kursic. The IDEF is a non-profit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. We have had multiple previous educational sessions, some given by Dr. King, Dr. Song, Dr. Glick, and others over the last several months. And today's session will be given again by Dr. Brad Glick. And as was just stated, Dr. Brad Glick is a very well-known and knowledgeable dermatologist and a good friend of mine. He will take us through this talk about Taltz and interleukin-17 therapies in psoriasis.
Well, Firas, thank you so much. And thank you to IDEF, Dr. Kursic, to RBC Consultants, and certainly to Lily for having us here this evening. All right, let's get these slides moving here. So Ashley will need a little bit of help with the moving of the slides because they are not moving. So I'm here this evening to talk to you about the efficacy and safety of Taltz in psoriasis and psoriatic arthritis. And there we go, thank you so much. So as you know, Taltz is an IL-17A inhibitor. It is the #1 prescribed antagonist in dermatology in this space. And really pretty recently, we know that it is citrate-free, FDA approved in this manner, which is a new formulation. We'll talk about some of the data that is related to this new approval this past couple of years in terms of the formulation of Taltz. So as you know, I'm here on behalf of Lily. I'm a paid speaker. There's no CME provided for this talk, and the goal of the program is to really review the information pertinent to this topic, the subject matter of psoriasis and psoriatic arthritis. Questions that will come up will need to stick to the label. I'll respond during the program as best I possibly can, but anything that is off-label will not be addressed. And I am more than happy to provide my email should you want to ask me an individual question. I'm sure that RBC Consultants and or Lily can provide such. So here are the indications for Taltz, and this group a very well-educated group in dermatology will know the indications for Taltz, and it's approved for psoriasis and psoriatic arthritis. But to me, as a practitioner of dermatology, what's unique about this product is that it's approved down to the age of 6. Those are for individuals who have moderate to severe plaque psoriasis and who are candidates for systemic or phototherapy. Those adults with active psoriatic arthritis, adults with active ankylosing spondylitis, and adults with active non-radiographic axial spondyloarthritis with objective signs of inflammation. And when I see a product that is approved down to the age of 6, to me that provides a lot of comfort regarding safety when I'm choosing a therapy. The drug is contraindicated in anyone who's known to be sensitive to it or any of its excipients. Certainly, Taltz, like any other biologic therapy, is a foreign substance, and these type of hypersensitivity reactions may occur, and some did occur in the clinical trials. The most common consequences of the drug were infections in the clinical trial and also injection site reactions, particularly in the control period. We'll talk about that. If we counsel our patients when putting them on any biologic therapy, by far and away the most common consequences of these biologic therapies tend to be infections, where we did see a higher rate of infections in the Taltz treatment group in the control period compared to placebo, although it's 27% versus 23%. Suffices to say that patients in clinical trials get infections and they get colds in general. We need to screen our patients for tuberculosis before putting them on any immunosuppressive therapy, and Taltz is certainly no exception. What is Taltz? It's a humanized IgG4 monoclonal antibody. It selectively binds to an important contributory cytokine that we know plays a very relevant role in the inflammatory process of psoriatic disease, both skin and joints. We know that Taltz inhibits the interaction between IL-17A and its receptor. It is humanized, as I indicated, and it has a very low concentration as it relates to its dissociation constant. Well, what's the significance of that? Well, the significance of that, it reflects its binding affinity. And we look at secukinumab just by comparison, and that has a higher dissociation constant. That is a human IgG monoclonal antibody. Now, whether this creates differences that we might be able to ascertain therapeutically, we don't know. But one thing we do know about Taltz is that it has a high binding affinity. It's highly targeted. We know that in psoriasis, IL-17A is elevated in the skin and in perilesional and non-lesional skin, and we know it's significantly elevated in the synovium of individuals with psoriatic arthritis. Let's talk about the multitude of clinical trials as it relates to Taltz. At the top, you see Uncover 1, 2, and 3. Those were the registration trials, those trials that led to the approval of Taltz. The co-primary endpoints in those trials were the proportion of patients achieving PASI 75 at week 12, and also the proportion of subjects in the trial with a static physician's global assessment of clear or minimal disease from baseline, and that required a 2-grade improvement from baseline. Remember that this is also subjects in the trial that were severe. Those individuals had to make a 2-grade improvement from baseline at minimum, which in that case meant they really needed to make a 3-grade improvements, which really speaks to some of the efficacy data and the challenges for those subjects in the clinical trials, because they needed to go from a 4 to a 1. Exora-R, a head-to-head comparison versus Tremfya, standard dosing regimen for both those drugs, and we'll look at the dosing regimens in a few moments. The primary efficacy endpoint was really a leap of faith on the part of Lilly, and we looked at 12-week data at PASI 100 from baseline out to week 12. Exora-Q, another revolutionary clinical trial that was actually performed by Kate Ryan, who's now in Ireland, the first and really only FDA labeling for genital psoriasis for adult subjects in this clinical trial, with a primary endpoint that was evaluated with standard dosing of Taltz with a starting dose of 160 milligrams, as we normally do for plaque psoriasis, and then 80 milligrams every 2 weeks thereafter, with a static physician's global assessment of clear or minimal disease, again, with a 2-grade improvement from baseline. And those subjects in the clinical trial also had background moderate to severe plaque psoriasis. Very challenging trial. Here are some psoriatic arthritis trials. Spirit P1 and Spirit P2, as you see at the bottom, were those registration trials that led to the approval of Taltz for psoriatic arthritis in adults. And that actually had an active reference arm in Hougeir, and we'll talk about what that means in a couple of moments when we look at the clinical trial data. Unique, for me, was the head-to-head trial versus, at the time, the market leader for psoriatic arthritis of Hougeir. This was an adult trial, a phase 4 trial. Primary efficacy endpoints were the proportion of patients achieving what I like to call a multiplier of ACR 50, not ACR 20, as we see in the registration trials and most registration trials for psoriatic arthritis, but an ACR 50, so a 50% improvement in those tender and swollen joints and those other parameters that are physician observed, patient observed, inflammatory markers, and also peer review, patient reported outcomes, I should say, PROs. And then the efficacy points there, as I indicated, were also achieving a very high bar simultaneously of PASI 100. Some additional clinical trial data that we'll look at tonight, and you may or may not have seen this previously, they're very simple trials, but nevertheless, crossover injection pain study and also a citrate-free bioequivalence study. Now, when you're going to change your formulation, and one of your hopes is that it goes from being citric acid containing, which is, probably create some of the injection site reactions that you might have in a clinical trial. As we'll see when we look at the data, that Lilly was very conservative in evaluating their injection site reactions. Pain was simply an injection site reaction. Simple redness and pain were injection site reactions, but simple pain really could have been an injection site reactions. And so the thought was to create a formulation that might reduce some of that pain. And we'll look at some of that data in a couple of moments. Now, the unique thing about this trial is that the subjects were randomized 1:1:1 to receive a single 1 cc subcutaneous injection of Taltz, the original formula, and 2 different citrate-free formulations. And the citrate-free #1 is the one that became FDA approved, and that's the data that we will look at. And so the pain intensity was looked at a VAS score, or a visual analog score, a VAS score from 0 to 100. And you'll be impressed by the data there too. There's a significant improvement in the citrate-free Taltz. And then if you're going to change the formulation, you have to show that it's bioequivalent to the originator formulation, and we'll be able to show that in that we looked at these subjects in this citrate-free bioequivalent study who were in different age ranges to show kind of a real-world presentations, lower than 70 kilograms, between 70 and 80 kilograms, and above 80 kilograms. And then in looking at the dosing regimen, which is the standard dosing regimen for Taltz in terms of its concentration of 80 milligrams, we looked at the bioequivalence by measuring the maximum concentration of the Cmax versus the time for the area under the curve for izokibep from time of injection all the way out to week, day 85, if you will, too, but just short of about 3 months. So Taltz has an established long-term safety profile. My hope is that those of you that are listening in this evening have tried Taltz previously, and we've got a lot of clinical trial data for efficacy and safety, long-term safety profile that's out to 5 years, 15 years of global clinical trials, over 6,000 psoriasis patients that were treated in the adult studies, 17,000 plus patient years of exposure. No boxed warnings or routine lab monitoring that is required. There's adjudicated inflammatory bowel disease events that were low and infrequent, less than 0.5%. And we'll talk about that as that relates to some background data that we know of, whether it's surveillance, epidemiology, and end result data, or what we know from the general practice data bank in Denmark from our colleague Alex Edgeberg. So these adjudicated events, when we look at those, are very low in number, and we'll look at the rates of candidiasis, which were less than 3% overall and did not lead to discontinuation of Taltz. What do we get with Taltz? Well, we get symptom improvement both in skin and joint disease and psoriatic disease, rapid efficacy in psoriatic skin disease, clearance that lasts, complete clearance. We've got PASI 100 data, We've got powerful joint symptom improvement, and we have radiographic inhibition with this agent, inhibition of radiographic progression of disease. Who are the candidates for Taltz? Well, anyone struggling with psoriasis in general, even in challenging to treat areas like the scalp and the nails, and others like palmar-plantar. And in the genital areas, we said that there is labeling the only biologic therapy, and for that matter, the only systemic therapy, where there was a dedicated study looking at genital psoriasis, and where there is a label confirmation that it can be used in this setting. And certainly as an IL-17A blocker, and certainly with this drug, as we look at the clinical trial data, we can see quick improvement with long-lasting results. So let's jump in and look at the clinical trial data. So Taltz demonstrated complete and consistent clearance. And what I love about this slide is that it puts together the 3 registration trials. There was a placebo-controlled trial, and then there were 2 active comparator trials in Uncover 2 and Uncover 3, where the reference active comparator was actually that of etanercept. But we're looking at the consistent data. Look at the top of the bars, that they're essentially level, where we like to say 9-4, 9-7 or 4, or 90-70-40, 90% of the subjects achieving PASI 75, 70% or so of the subjects achieving PASI 90, and about 40% of the subjects in the clinical trials, in looking at this individual data from each one of the registration trials, showing these robust response. So about 40% of the subjects achieving clear skin at PASI 100. And if you look to the right, we have really comparably robust responses in terms of those subjects with the high bars of clear minimal disease. And through my lenses, I can tell you, when we looked at older data from some of the TNF inhibitors, and we will look at the high bar of clear or minimal disease with a 2-grade improvement from baseline, remember those 4s needing to go to 1. So a 3-grade improvement, 3 is going to either 1 or 0. We used to see the clear or minimal disease data kind of lower percentages, and you have 80+% of the subjects in the clinical trial achieving clear or minimal disease. And this is a very high bar. And so for me, when I look at clinical trial data, I find that impressive. Now that's all control group data. Let's look at long-term data, because that's what we want to know. I mean, we look to the left here, and in week 12, we see that really sharp incline. We see the provision of PASI 75, PASI 90, and 100 responses that are very rapid with Taltz. So that's great for someone who needs to be clear quickly, but what about long-term? This is as observed data. And if you look all the way out to 5 years, we have 97% of the subjects at PASI 75, 90% of the subjects at PASI 90, and close to 2/3 achieving PASI 100 by this as observed data. Now, sometimes we'll get asked, what does it look like in a modified non-responder imputation? And if you look at that at the bottom, it doesn't change things that much from the perspective of what we said in the control period. We have a very high bar, and we have significant improvement at 90, 70, and 40, PASI 75, PASI 90, and PASI 100. And we're able to sustain and have that consistent response all the way out to 5 years in those individuals that are responders. And as you all know, long-term data is enriched. But this is what we want to be able to tell our patients, that if you are responding, you have a very high probability of achieving a continued 75% improvement or a 90% improvement if you're 90% clear, and you're able to even maintain clear skin pretty much at least 40% of the time by the statistical analysis, which is a little bit more stringent at an NRI, as we saw on the previous slide. Once again, we see the quick improvement in the control period of the clinical trial. And this is actually data that looks at absolute PASI scores, the mean improvement in those absolute PASI scores from baseline. So you see that rapid turn up. But can we consistently sustain those responses? And I think looking at absolute PASI scores is perhaps an even more clear and real-world assessment about how subjects do in clinical trials. And we have a 97% mean improvement in those PASI scores from baseline out to 5 years. And overall, patients maintain over 90% clearance through 5 years, depending on how one looks at the statistical analysis. And if you look all the way to the right, And what is particularly impressive is you consider that the average PASI score out to the left is about 20, almost 21, and at the end of 5 years, it's 0.7. These are impressive responses that subjects in the clinical trials were able to achieve, and I think that we see this as well in clinical practice. XORA-R was a head-to-head trial. This is 12-week data compared head-to-head between Taltz and Tremfya, standard dosing, which you know for both drugs. But as a reminder, the Taltz was injected 160 milligrams at baseline and then 80 milligrams every 2 weeks thereafter. That is the standard first 3 months of drug, and then of course, typically it's 80 milligrams monthly thereafter. And for Tremfya, it's 100 milligrams at 1 month, and then every 12 weeks, every 8 weeks thereafter. And if we look at the high bar for this trial, as I mentioned when we looked at the clinical trial setup in the prior slides, a PASI 100 at week 12, we have 41% of the Taltz treated subjects at clear skin by PASI 100, with statistically significant difference compared to just about a quarter of the subjects in the Tremfya group. Impressive to me, as we have seen this type of step-down approach previously. The step-down approach creates a primary endpoint. Here it's PASI 100 at week 12. But then there are really high bar secondary endpoints. PASI 50, you might say, PASI 50, what's important about that? But it's at week 1. PASI 75 at week 2, PASI 90 at week 4, and so on. And all the other secondary endpoints were met in this step-down approach, all with strong statistically significant differences versus Tremfya at week 12. And so all of these key efficacy endpoints were met. It's nice to see what happens in the skin overall, but what about difficult to treat areas like the scalp, like the nails, which, as we all know, the scalp and the nails are potential harbingers or reference points for us for the possibility of psoriatic arthritis. And so, of course, I remind the audience to please screen at every visit. Use that psoriasis epidemiology screening tool, the PES screening tool. But here we see 12-week data that looks at clear scalp, clear nails, clear genitalia, and clear palmar plantar regions. And the data shows that 80% of the subjects with standard dosing regimen of Taltz were at a clear scalp, 18% with clear nails. Now remember, some of the audience might say, well, that's a really low number. But remember, with the fingernails growing just about 0.05 to 0.07 millimeters per day, very slow, we won't expect a lot of growth in a clinical trial for psoriasis. Week 24 and actually 1 year are probably better endpoints. Nevertheless, more than half the subjects in the genital psoriasis trial, the XORA-Q trial, achieved a clear or complete improvement of the genital psoriasis, and just about 2/3 achieving palmar plantar PASI 100 in just a short 12 weeks in the controlled period of the this post hoc analysis, or extracted data, as I like to call, from Uncover 1, Uncover 2, and Uncover 3. But it's really nice to see not only what happens in the control period where difficult to treat areas are concerned, looking at data head to toe as we see here, but what about 5-year data for scalp, for nails, and for palmar plantar disease? And the numbers rise. 87% compared to 80% at week 12. So we have a 7% capture. Look at the difference in the nails. Okay, by year 5, 3/4 of the subject were able to clear their nails. And in my opinion, and in some patients that I have that are on Taltz that have nail disease, actually, this is one of the more impressive therapies that I use when I see patients having background nail disease. And it's comforting for me, whether they have concurrent psoriatic arthritis or not, I at least know that I'm treating a component of psoriatic skin disease that may be a reference point for future development, or hopefully not, of psoriatic arthritis. Clearance of the genitalia was only studied out to 1 year, but we have 60% of the subjects where we have a 4% greater capture rate by the end of 1 year, and about 90% of the subjects have clearance of their palms and their soles. Very impressive and very difficult to treat in that area. This is just some nice data also looking at complete clearance, some post hoc analysis data from the XORA-R study. So remember, see that green and that blue, this is the head-to-head comparison between Taltz and Tremfya. And so we see 63% of the subjects versus 44% in the Tremfya treatment group achieving clearance of their fingernails by the Physician's Global Assessment for fingernails in terms of nail responses. And over 7 out of 10 of the Taltz patients achieved this high bar all the way out to week 24. And as you see, even if it's a different reference point, NAPSI versus clear nails, 24 weeks is a better reference point. We need that time to be able to assess those nails that are growing slowly. And this is just a very nice example, an image from a Taltz patient who received standard loading dose, 2 80 milligram injections at week 0, and then 80 milligrams every 2 weeks thereafter. And we see at week 0 a response, and then what the nails look like at week 24. And we can see this in clinical practice. To the left, you see some onychorexis, some onycholysis. Perhaps there's even a little oil droplet sign with, almost complete clearance. You look at that right little finger, and there's probably still a little bit of distal onycholysis noticed there. Nevertheless, pretty impressive response. And as I alluded to before, nails and scalp are potential harbingers for psoriatic arthritis. And we know that about up to 30% of patients with psoriasis in general may very likely move on to develop psoriatic arthritis. And so it's important to know that the presence of scalp disease, the presence of nail disease, individuals are 4 times and 3 times more likely to develop psoriatic arthritis when they have these difficult to treat areas in the background of their plaque psoriasis. What about psoriatic arthritis? Well, we see powerful joint symptom improvement in PSA at week 24 with a non-responder imputation, just like we saw in the control period data for Uncover 1 and Uncover 2 and Uncover 3 in those control periods. And so that non-responder imputation here is at week 24. This is 80 milligrams of Taltz every 4 weeks, as we do for patients, our rheumatology partners do for our patients with psoriatic arthritis, our adults with psoriatic arthritis. Important for the group that if you're collaborating with a rheumatology partner who's about to start a patient on Taltz and they have moderate to severe plaque psoriasis in the background, we'll want to do that 80 milligrams after induction of 160 milligrams, 80 milligrams every 2 weeks, and kind of collaborate with your rheumatology partner, because our patients should do a whole lot better, particularly in those first 3 months at that higher dose that we have for plaque psoriasis. Here is the registration trial data in Spirit P1 and Spirit P2. So Spirit P1, we have bio-naive patients. In Spirit P2, we have TNF experienced patients. And we see what we want to see in clinical trials for psoriatic arthritis. About 60% of the subjects achieving ACR 20, about 40% of the subjects achieving ACR 50, and about 20% of the subjects achieving ACR 70. And we see this here, that's in the bio-naive group, and pretty close to the same data with a very nice separation between treatment group in those TNF experienced patients versus the placebo treated group. We'll often see even higher placebo responses. We see them to the left here in the bio-naive trials, but remember, many of these subjects might be on low dose prednisone. They may be taking methotrexate. At least 50% of the subjects in this trial were taking methotrexate, and perhaps even some other disease-modifying anti-rheumatic agents. We know that Taltz inhibits progression of structural damage in patients with psoriatic arthritis. We see this as early as week 16, as we see here. You'll notice in the prior data, there's that reference arm of Hougeir. Very much similar data. We see it similar here, that we're able to achieve radiographic inhibition of psoriatic joint disease. We see it early on here. We see that green bar at 0.11, very close to what we see in the reference arm. This is not a statistical comparison, but nevertheless, we're able to achieve inhibition of radiographic progression with Taltz. And you see that placebo arm all the way up at 0.36 for the modified total sharp scores, elevated for the joint space narrowing, and also significantly elevated where bone erosion scores are concerned. And so we're able to achieve this very important ramification of inhibition of radiographic progression of disease in individuals with psoriatic arthritis. So for me, this is a very important slide. As a clinician who's very concerned about those 30% of my patients that may be developing psoriatic arthritis or that may move on to develop psoriatic arthritis, this is a very high bar from the Spirit head-to-head primary endpoint. This active comparison now between Taltz and Hougeir, looking at this primary endpoint of a combination of achieving ACR 50 and PASI 100 at the end of week 24. We see this statistically significant difference where 36% of the subjects in the Taltz treatment group versus 28% of the Hougeir treated individuals achieve this very high bar of a multiplier of both of those scores. And the numbers actually increase for Taltz over time, a 3% capture rate. And we see this wide separation between treatment group and Taltz versus Hougeir out to a full year. And so we've really come a very long way, not only in how we have therapies like Taltz to treat the skin, but the improvements that our patients can get in treating their joints. So we see that therapeutically speaking, Taltz work. We'll talk about safety in a couple of moments, but the formulation has been changed. And so, when I went over some of the information about the citrate-free formulation, one of the things that we want to be able to look at is it less painful? What are the individuals that were treated with the originator formula versus the citrate-free CF1, as I mentioned before? Did they see a difference in pain? And you see these just significant numeric differences where the visual analog injection site pain score was very high in the originator formulation and just 3.5 on that 0 to 100 scale in the citrate-free formulation. And I'll tell you an interesting story. I had one of my patients who said, "Doc, I think that there's something wrong with my Taltz because when he did his last injection, he thought maybe he missed or something went wrong, or maybe they didn't give me the right stuff," because he said he didn't really feel it when he was getting the injection. And so I explained to him, and on this slide, it really references this as well, that he may not have known about the change because, a lot of the companies that have changed their formulations made it into a bigger deal in that there had to be a new NDC, a new number. There was a need for a new prescription, that there was a new prior authorization required, or there was possibly a gap in therapy because of insurance. And none of that is the case with citrate-free. And I think by far and away, all of our patients are getting citrate-free Taltz at this time. And so 98% of people reported no or mild injection site pain in the clinical trial. In terms of adverse reactions and infections through week 12 in the psoriasis trials, the registrations trials, this is cumulative data, adverse reactions that are about 1% or greater in Taltz subjects in the clinical trials versus placebo. And actually there was a higher rate of injection site reactions compared to placebo. This does improve over time, as we'll see in a couple moments. And remember, as I said before, the bar for injection site reactions was really placed very, very conservatively by Lilly, in that just pain, simple pain, or a redness at the site, limited redness at the site, not necessarily what we're used to with induration of the site, was considered an injection site reaction. But many of our colleagues have seen some urticaria and some significant injection site reactions, but they do improve over time. We see upper respiratory tract infections very similar between treatment group and placebo, yet about a 1 percentage point greater in the Taltz treatment group. And then some nausea, tinea infections, and the rates of serious infections, which concern us in clinical trials for biologics, were identical between treatment group in Taltz and placebo. Nice to see what happens in the control period, but what happens long term? And I can safely say, when we look at all 15 trials where Taltz is concerned, and we look at adverse events that really concern us, those adverse events of interest, serious infections, Candida infections, hypersensitivity reactions when they're non-anaphylactic or potential anaphylactic, inflammatory bowel disease, non-melanoma skin cancer malignancy, and those injection site reactions. And we really see a trend downward year by year. And this is over 6,000 adult patients across these 15 clinical trials. And so we see this improvement over time. The average and median Taltz exposure durations for these patients were 996 and 718 days respectively. So there's a lot of very helpful data here. And we'll dig into this even a little bit more in some of the upcoming slides before we close. And certainly where IL-17 inhibitors are concerned, we have concerns about inflammatory bowel disease, new cases of inflammatory bowel disease. Remember that inflammatory bowel disease was indeed an exclusion in the Taltz trials, but nevertheless, if we look at the numbers, if we look at Crohn's disease, if we look at ulcerative colitis, these numbers are quite very much in the low range as we look at these incidence rates per 100 patient years. And if we look at peripheral data, like from SEER type data or data banks like the Denmark General Practice Data Bank, which looks at groups of psoriasis patients and those that may have background inflammatory bowel disease, and when you appropriately match them for controls, these rates actually fall below what we would expect in a large population of psoriasis patients. And so clearly our patients need to be counseled about inflammatory bowel disease, but I think the concern factors do not reference a particular safety signal where Taltz is concerned. These numbers are generally low as it might relate to the unleashing of inflammatory bowel disease in individuals going on an IL-17A inhibitor. So for adults with moderate to severe plaque psoriasis, we can consider Taltz in individuals who are struggling with their treatments and on other therapies, or if they have challenging to treat areas like the scalp and the nails, and we referenced before also the genitalia and palmar plantar. Those wanting rapid clearance, as we saw in the clinical trial data, and those that want long-term complete clearance, as we saw from some of the long-term data earlier on. Access is everything. You know, if you can't get a drug, it doesn't help our patients. We have great access with Taltz. As you see here, best access for IL-17A antagonists for treating psoriasis. The Taltz Together program is quite helpful. Cover My Meds, using the Lilly support provider portal, also very helpful. And as always, you know, have a close relationship with your pharmaceutical sales representatives and the account benefit specialists, those field access specialists that help us get these drugs for our patients. We talked about hypersensitivity reactions. Fortunately, they occurred at a rate of about 0.1%, just or less. We talked about inflammatory bowel disease and the low rates of inflammatory bowel disease that did occur in the clinical trials, although there were some cases, but they fall what we would expect in a large population, such as in the clinical trial for inflammatory bowel disease and for individuals being treated with a IL-17 blocker like Taltz. Live vaccines and age-appropriate vaccines should be administered before any immunosuppressive agent or any biologic therapy. Adverse reactions we've gone over, which most commonly appear to be injection site reaction, URI, nausea, tinea, infections. And we saw very similar safety panel and profile in some of the other approved disease states like psoriatic arthritis, ankylosing spondylitis, and non-radiographic axSpA. And also in the pediatric population, perhaps with the exception of some flu and conjunctivitis in the psoriatic arthritis trials and some conjunctivitis, influenza, and urticaria in the pediatric trials. And, you know, those are conditions that we expect in the kiddos. So with that, Dr. Hougeir, I am finished. I'm charged up here, and I'm ready to answer any questions that our group may have. Thanks so much.
Thank you so much, Dr. Glick. Excellent presentation, as expected. Thank you for talking to us about the data and about what we see in our patients. Talking about our patients, you know, you went over quite a bit of data with different psoriasis and different subset of psoriasis. Out of this data, what do you find most important or very important for your clinic from a practice standpoint?
You know, as you can see for us, first of all, great question. And you can see as I'm going through the data, and there's a lot of it, and we've been able to accumulate a lot of information in Taltz in this last 5 or 6 years, really since it's come to our toolbox. You know, but we talk a lot about background psoriatic arthritis. We didn't talk a lot about axial disease tonight, but I'm particularly concerned when I size up my patients that do they have background psoriatic arthritis? So I'm seeing some nail pitting. Are my antennas up? Do I have to engage my rheumatology partner? But I'm thinking about more than just the skin. I'm thinking beyond the skin. And as I look at the whole patient, one of the most impressive data points for me is that what I like to call the multiplier. I think achieving clear skin and ACR 50 is an incredibly high bar. And I think you'll agree that our rheumatology partners say that ACR 20 is kind of a lower bar. You know, it's kind of our PASI 50 response. And we'll see clinical trials for psoriatic arthritis develop into primary endpoints at ACR 50, and that's now consider the higher bar. So when you achieve ACR 50 and you achieve clear skin, to me, that is a dramatic result. And so that's what speaks to me when I look at all of this data.
I agree. I think psoriatic arthritis is a huge part of our job as dermatologists when it comes to identifying it and starting the treatment, because we see it earlier and we can diagnose it in a way, in an easier way than some of our rheumatology colleagues, because our patients already have psoriasis and they're in our clinic for that. And having such clearance rates, high skin clearance rate with good psoriatic arthritis improvement is also has been a great achievement for drugs like Taltz. We are coming to the tail end of this, actually, so I know there are many questions that could be asked. Is there anything else you would like to add, Dr. Glick, after this presentation?
Well, actually, I was going to ask you what your kind of view and your optics are as it relates to Taltz. Is it the same data point that I referenced? Is there something that in your hands and in your experience that you have seen is highly effective where Taltz is concerned?
Well, you know, we have data for genital psoriasis. We have data for multiple types of hard to treat psoriasis, like scalp psoriasis and such. I think Taltz in particular, and 17s in general, gave us a tool which has been a life changer for our patients. You know, before drugs like Taltz, we did not talk about almost clear. We did not talk about PASI 90s. We did not talk about PASI 100s. These are the drugs that really brought this tool where we can now tell our patients we have something to get you better. And that made a huge difference. And the approval of psoriatic arthritis was also in my clinic a game changer, because we always, as you say, in your clinic, we always look for psoriatic arthritis. We always try to get as clear as we can. And having data where the PASI 90 and the PASI 100 are so high with this biologics has been a great improvement for our patients' quality of life and our patients' improvement of their psoriasis and arthritis.
Yeah, I would share a unique comment that I have a couple of patients where I've had background plaque psoriasis that was in that moderate range, but they had really bad nail disease. And I just like the data for us, I've seen some dramatic change in the nails. And you might say, well, the nails are not so important. But I have a FedEx driver and a FedEx delivery man who I've taken care of for years, and his thick, hyperkeratotic, pitted nails were abysmal for him. And we've been able to clear them up. He's been on drug for over 3 years with clear nails. And so I think that's just something else that speaks to me.
I think we have to always remember that what seems like not much to us can be a huge, can have a huge effect on our patients' lives. And nails, to me, are a very important part of the disease to treat. All right. Well, with this, we are past our time. I want to thank everybody for being here. I want to thank Dr. Brad Glick for giving us such a great presentation. And I want to thank also, of course, Lily for being our sponsor and our supporter in this presentation. Thank you very much. Thank you, Ashley.
Thank you, everyone.